Hi, it's me. Today we're going to do a little recording on the cardiovascular assessment. So you've done your respiratory assessment. You know how this works now. What we're going to be doing is thinking a little bit about the anatomy of the body, the cardiovascular system in particular. We are going to look at the patient at the end of bed. We are going to take history. We're going to take OBS. We're going to consider the red flags which are present in cardiovascular conditions. And then if it's not time critical, we are going to go on and do a cardiovascular assessment. Right, so the things that I want you to do, first of all, let me just skim down a wee bit. Here we are. So the anatomy and physiology review. So I know that plenty of you already know about this resource, but how many of you have actually been to it, I do not know. So what you need to do is to log on as if you're going to go to EBSCOhost, as if you're going to go into the library databases. Within the A to Z, you go to V, and if you click on V, go to the visible body and have a little look at the chapters on the heart and the cardiovascular system. So what I'm going to need you to do is to know exactly whereabouts the heart sits and where are the particular valves on the heart, because we're going to be listening for murmurs. So get your anatomy right. Where can you find the 4 valves of the heart? Also have a look at the cardiovascular system. You need to know where the pulse points are. I think that's about it. Anyway, have a little review of that. I have given you homework, as you know, on the common conditions. Once you fill in those, we will be able to move on to our simulation and think about various examples and what problems the patients might be having. So what we're going to start with is this. All right, from current slide. Great. So as usual, we're going to give a systematic approach to the cardiovascular system. End of bed assessment. So we're going to talk a little bit more about this in seminar, but what kind of things do you reckon you'll be looking at for the end of bed assessment for the cardiovascular patient? So as usual, we'll have a little eyes around the room, have a little look at that, introduce ourselves, say hi to the patient says hi back. We know that their airway is intact and we know that they're breathing. Have a little look at the chest and see if they're breathing fast or slow. So you're thinking maybe that sounds a bit respiratory? Well, don't forget these two go hand in hand. So if a patient is having difficulty breathing, it's not always to do with the respiratory system. It's not always a lung condition. Sometimes it can be a cardiac condition. So we're looking at the patient, seeing how fast or slow they're breathing and is there any increased effort in the way that they breathe. Then we move on to circulation. So at the end of bed, you're going to be looking at the patient to see, first of all, are they pale? Are they flushed? How does their circulatory system look from the end of the bed without you touching them? Have a think now. Think about what kind of stuff you reckon you could tell from a patient as soon as you walk in. Look at someone in your room. Look at someone on TV. What can you tell about them? Can you tell if a patient's blood pressure is high or low just by the colour of their face? Sometimes you can, yeah. Anyway. We're going to look at their extremities. Circulation problems are quite often seen in the cyanosis of the peripherals. We're going to look at their hands and arms, moving up to the face and the head, looking at the neck and their jugular venous pressure. Then we're going to look at the chest, and as usual, we'll do IPPA. But obviously this time around, we're not listening and looking at respiratory conditions, we're looking at cardiovascular. And then again, we're going to look at the limbs and peripherals. So that will be repeated from what you did in the respiratory system. We'll be looking for the oedema, and then we'll also look at the pulse points. So like I said before, I am going to go over this with you in the seminar, but this is a snapshot of what you will be looking at the end of the bed. Okay, let's move on to the hands and arms. So this is a more focused assessment. Don't worry if you can remember things from the respiratory assessment. Sometimes they'll cross over. We're going to look at clubbing again. And clubbing is something that indicates a long-term respiratory disorder, but it can also be cardiovascular. So, like I say, these things are going to just double up on each other, and yeah, this is what you're looking for. So, circulation to the skin. Are they pale? Looking at the cap refill. Cap refill should be holding on for 5 seconds, let go. How long does it take for the color to come back? Should be less than 2 seconds. With pediatrics, sometimes it can be 2.5 seconds, but with an adult patient, we definitely look for cap refill to come back within 2 seconds. If that doesn't happen, what are you looking at? Ask yourself now. So, cap refill that's extended, why might that be? Pause me, because I'm going to tell you the answer. Pause me to think about it. All right, so we're thinking about shock. So, a prolonged cap refill can quite often mean that there's inadequate tissue perfusion. So you've done the shock on Richard's lecture. We're thinking hypovolemic shock. We're thinking other types of shock as well. The capillaries are not refilling as quickly as they should do. Have a look at the hands. Look for nicotine staining. We're thinking smoking. We're thinking the cardiovascular conditions that come with long-term smoking use. Splinter hemorrhage. I'm going to show you a picture of that and let you know what it is. Clubbing, as you already know. The temperature. That means basically checking the temperature of the skin and checking the pulses. Are our pulses the same? Check them at the same time. We're checking the pulses throughout the body. What's what? Oh, we know what that is, don't we? Okay, so clubbing, not only is it hypoxia and respiratory disease, it's also heart disease. So obviously, nicotine staining is a huge risk factor for cardiovascular diseases and myocardial infarctions. So we're asking the patient, not just are you a smoker, but how many do you smoke? How long have you smoked for? When did you start it? How many do you smoke a day? How many do you really smoke a day? So long-term use of nicotine and tobacco is going to lead to increased risk of heart disease. The splinter hemorrhage, now you can see in this, sorry about my thing there, I'm not sure I can move that out of the way. Oh, there we go. Okay, so these tiny little dots, which are just under the nails there, they're tiny blood clots, and that's produced by defective heart valves. So you're examining your patient's nails there, and if you can see splinter hemorrhage, that might be a sign of bacterial endocarditis. Do you know what that is? If you don't know what that is, let's break it down. So itis, that normally means inflammation of, so that normally means an infection. The endocardium is one of the three layers surrounding the heart. So it's a bacterial infection of the layer of the heart, the endocardium. So splinter hemorrhage could indicate a heart valve problem or bacterial endocarditis. As usual, think about the other signs and symptoms that come with infection. Do they have any chest pain? Are they displaying a higher blood glucose level? That can be MI. It can be infection. Are they displaying temperature? Are they displaying tachycardia, etc.? Which way are we going to go with this? Next. Okay, so face and head. We're going to be moving up, having a look at the general skin colour. So checking whether it's flushed or whether it's pale, whether it's ashen, whether it's blue. So a patient who's having a cardiovascular event, such as a myocardial infarction, will quite often appear to you as grey, ashen, that kind of a look. Quite often you can walk into a room and you can look at the patient and say, yeah, they look a little bit cardiac. But that's not to say that if a patient is pale or blue or red, that they're not having a cardiovascular incident. So take a note of what you can see with the patient's colour. Ask the relatives, is this their normal colour? Looking around the eyes, I'm going to show you some pictures of these in a moment, but we will look for jaundice, arcus senilis, exanthelasma, anemia, and then we'll look at the face colour again, and we'll look for malar flushing and cyanosis. As you know, with our quiz the other day, we need to know where to find pallor, where to find cyanosis in brown and black skin patients. So we're looking at the mucosa, the gums, around the nail beds, and we might even be looking under the eyelids too. Come on. Sorry about that. All right. So Orcus senilis. This is this picture down here, which freaks me out a little bit because it looks like a fish eye. So it's the kind of the white, grey, bluey ring just around the cornea there. And this can be a sign of hyperlipidemia. You'll see that quite often in older patients. Do you know what hyperlipidemia means? If not, you can look it up, pause me, or I'll just tell you, it's high cholesterol. Now, jaundice we've seen in the respiratory system as well. So with jaundice, we're looking in for a yellow tinge. And normally when you see this yellowness, we're thinking about the liver. So with liver failure, that also links to the circulatory system and the cardiovascular system because it can have an element of clotting disorder in there as well. So it's relevant for us. Exanthelasma, you can see with this patient, we have these fatty deposits around their eyes. And that is, again, hyperlipidemia or high cholesterol. Think about high cholesterol in the cardiovascular system. We've done this in Pat Pass's module. When the atheroma builds up and builds up, the plaque builds up, becomes dislodged, it can travel around and cause a myocardial infarction or a stroke. Here's malar flushing. So this is this nice rosy look. Don't get it mixed up with other flushed looks. But basically, it's flushing in the cheeks that it's kind of constant. So these patients will always look like this. It's more obvious there in the top patient. So not to be confused with other conditions. There's a Rosario condition. There's also, don't forget about carbon monoxide poisoning. Carbon monoxide poisoning can make you have a very rosy red cheek appearance. Also looks a bit like alkoflush, but alkoflush, as we know, goes away as the day goes on. Right, let's move down to the neck. Now, this is really, really important. So if you didn't earlier on go into the visual body atlas, do it now. We need to know the veins of the neck. And it's not only for this module, but it's also for Richard's module because you will be cannulating the external jugular. So I personally need you to know where the carotid arteries are, and I need you to know where the inner jugular vein and external jugular vein are. So this diagram here is quite complex, but those are the things that I need you to know. So first of all, we'll have a feel of the carotid arteries. Don't feel at the same time, because if you're feeling a little bit hard and you push in on them and you stop the blood flow from both sides of the neck, you might do yourself a bit of damage. Okay, so we know where our carotid arteries are. Let's have a little feel. You can feel with your own pulse at the same time as well. Are they beating the same? Or are they beating together? All right, now we're going to look at the internal and the external jugular veins. The reason why we're doing this is because we are going to measure the jugular venous pressure. So for that, we need to find the internal jugular vein. Now, the external is going to be easy to find because that's the one that you're going to be cannulating and it goes at an angle. Whereas the internal, you don't tend to see it or feel it. So you need to know where your anatomy is for this. I'm going to go on to the next slide because it tells you to be in a certain position. If you're straight up like this, like that neck is, you might not necessarily ever be able to find the internal jugular vein. So get the patient into the correct position first. All right, so here we go. So the patient's laying down flat on the bed. Then you tilt the bed up to about 30-45 degrees. Get the patient to turn to the left. You're going to see this in the right side of the patient. Now, you might not see it on me because I'm not sitting at the 30-degree angle. Basically, what you're going to do from here is, with the patient facing away from you, you're going to look at their external jugular vein, then their internal jugular vein, and then you're going to measure venous pressure. So I have set you a video on this, as it can be quite complex for people to do. But basically what we're doing is we're checking for the pulsation in the vein, and then we're going to measure how far it is away from the sternal notch. But as you can see here, you have to measure across and up. So here's your sternal angle. Here's where you detect the pulse. Measure across and level with the sternal angle. It's this tiny, tiny little measurement here that we're interested in. So what we're actually looking for here is how many centimeters in height is that? Because that's going to be significant as to whether you've got increased jugular venous pressure. Watch the video on it and you'll see it is quite a tricky thing to do, but once you know how to do it, it's quite easy, don't worry. Moving on to inspection, once you've measured the jugular venous pressure. So what can you see? Let's expose the chest. Let's take off the shirt. We're looking again at things from the respiratory system. So we're looking for equal bilateral chest rise. We're looking at the expansion. We're looking at any kind of sign of pain at all on the patient. We're looking for any abnormalities. So you might see some scars. Could be a pacemaker that's fitted there. You'll normally see a pacemaker right up here. Sometimes patients forget they've got it. So if you say any medical history and they don't even bother to tell you, but you might see a little scar up here. You might see masses. So we've talked about masses before in terms of bruises, broken ribs, trauma, and also cancerous masses. Looking for pulsation in a mass as well. So, sorry, I'm looking at the bottom of this. It just says any more suggestions. What is a pulsating mass? Where might you find it? So, pause the video and think about this. Have you ever been taught before about a pulsating mass? So, what I'm trying to get at here is an abdominal aortic aneurysm. So, we know the aorta is the biggest, massivest blood vessel in the body. It's around the heart. If we get an aneurysm in that, that means the wall has become weak and there's a bit of a leakage in the wall. So some people have these aneurysms. They get measured, and if they're only small, then people live with them. Once they rupture, it's big, big trouble. So you can imagine the greatest blood vessel, the aorta, having a rupture in it. So that means it's torn. Whatever the bubble bursts, the blood is going to go really fast out of there. So when you have an abdominal aortic aneurysm, quite often you might see a pulsating mass, and that's at the bottom of the aorta. So it's around about here. So between your ribs, you might inspect and see, oh, I can see a little pulse there. Tell you what not to do. Don't go and poke it, because you might burst it. Have a look at the pulsating mass. Is it really pulsating? Is it a trick? If it's a pulsating mass, you'd be thinking, oh dear, let's get to hospital quick. This person needs surgery. Now, one way to check for abdominal aortic aneurysms is in the blood pressure. So the blood pressure, because of the way that the blood is pumping and how it goes around the body, blood pressure will be different from one arm to the next. So what we're looking for is a marked difference. So if you have a systolic on one side that is 100/60, and then you measure the other side and it's like 70/40, that can be an indicator of an abdominal aortic aneurysm. That is a blood pressure that's different by 20 from one side to the next. Feel the pulses on the wrists as well. Are they beating at the same time? If there's a delay, that can also be a sign of an abdominal aortic aneurysm. I should just say AAA. That's what they're called on the road, AAA. So if you see these patients, this is a really time-critical job. What you might, the signs and symptoms they might they might present with are the low blood pressure, the high pulse rate because the heart is trying to pump faster as blood is not getting to all of the organs, and you might see them being quite pale. In terms of what the patient will present with, sometimes it's a chest pain or a back pain, and it feels like a ripping sensation. These patients don't have long. Time critical. So if you need to look up any more about AAAs, please do so. Again, pretty interesting. Palpation. So don't be alarmed when you see this. Thrills, heaves, pulsations, lifts, murmurs. These are all the words that come along with a cardiovascular examination. When you watch the Geeky Medics video, this will become a little bit clearer to you. So what we're actually doing is we are trying to feel for pulsations on the patient's chest, but we have 3 different types that we can feel. So as you can see there with the coloured, the localized pulsations we will feel with the fingertips. That's basically if you feel a pulsation and you want to find exactly where it is, use your fingertips. Well, what you'll mostly be doing, first of all, is just feeling for thrills and heaves. So with your hand flat, you will be positioning it on the patient and feeling in intercostal spaces for either vibrations or your hand actually lifting. So when you do the video, you will notice that the thrills are the pulsations and the heaves are the lifting of the hand. So let me just put it on a little bit and show you where to feel and what these actually are as well. So a thrill is a palpable vibration caused by turbulent blood flow through the heart. So that's basically a heart murmur that you can feel. So with the thrills, you're going to feel with this part of your hand. You're going to put it across all of the valves, and you're going to be feeling for a palpable murmur. Okay, so like I say, you will see this in the video as well if I'm not making complete sense to you. Heaves, that's a lift. So it's basically what happens is a patient with right ventricular hypertrophy will give you a vibration that actually lifts your hand up when you're feeling their valves. When we're doing palpation, we're also going to feel the apex beat of the heart. So this is where you need your anatomy. We need to know, first of all, where the 4 valves are, and then also where the apex beat is. So to find the apex beat, it's literally going to be, on men, it's just below the left nipple. But the best place to find it is to go to the midclavicular line and down into the 5th intercostal space. So you're going to feel, first of all, you put your hand flat and feel where you can feel the heartbeat. And then you're going to swish your hand around, and with your 2 fingers, you're going to be feeling exactly where the apex of the heart is. We're going to listen to heart noises as well. Now, you do have a separate video on this as well, but the video will tell you lub-dub. That's all I want to know. I want to know, can we hear the valves opening and closing? Is it just a normal S1, S2? That's lub-dub, lub-dub, lub-dub. Or are there any extra sounds? There are loads of different names of sounds here, but all we're looking for is either the plain lub-dub or I can hear something extra. And if you can hear something extra, you can go and look it up if you want to. That's fine. But for this course, all you need to do is know that there is something else there. It might be a murmur. You might have a leaking valve. But we can say normal or abnormal. So we need to find exactly where these valves are. So we have got the aortic, which is in the 2nd intercostal space, just to the right of the sternum. We have got the pulmonary, which is on the other side of the sternum to the left. We have got the tricuspid, which is in the 4th intercostal space. And then we have got the mitral, which is midclavicular, 5th intercostal space. Now, I want you to listen to all of those on somebody, whether you do it in the classroom during the skills session, or you do it on somebody at home, or you do it on yourself. I want you to listen and distinguish the lub-dub. Turn your steth round. Listen with the bell side. What can you hear? So with heart noises, it is more effective to listen with the other side of the stethoscope. So have a little play with that, turn it round, try it on somebody, try it on yourself. Here are the locations. Move that out of the way for you. All right, just take a note of this. If you've got your stethoscope handy, pause me, do it on yourself. See if you can find these. Like I said before, try both sides of the stethoscope. Which can you hear it best in? Do you just hear a lub dub, or do you hear any extra noises? So, how many heart sounds can you hear? We should only hear two. We should only hear the lub dub. Tell us if there are any additional noises. And you might hear murmurs, which is a kind of a whoosh noise. That's all you need to do. All right, don't go looking up all of the other gallops, etc., because it might do your head in a little bit. Excuse me. Oedema, we're doing the same as we did for the respiratory system. So sacral oedema and pitting oedema. Remember we talked about heart failure in this before. So it's a pump problem, excess fluid. This isn't new to you, so hopefully you remember this from before. You'll remember the heart failure. You'll remember the pink, frothy sputum. You might hear crackles with this as well. So, like I said before, it crosses over between the respiratory system and the cardiovascular system. Then lastly, we're going to be checking for pulses. Can you feel all of these pulses? This looks like a pass question for the ANAT exam. I don't know why people didn't score 25 out of 25 for this one, but it's pretty easy. So this is where we'll be finding all of our pulses. We need to know where they are, and we need to check them if we're doing a cardiovascular examination. That is it. Please do watch the Geeky Medics video. I'm aware that this is a little bit more complex than the respiratory system, but it's only because it's new to us. So practice your JVP, practice your thrills and heaves, practice the valves auscultation. Then we're going to go into class and we're going to do some more case scenarios and studies to see if we are any good at diagnostics. So do your homework and I shall see you soon.